Good morning. Thank you for the opportunity to present today. We do not have anything to disclose. To begin, enhanced recovery pathways or enhanced recovery after surgery ERAS protocols are multimodal perioperative care pathways designed to achieve early patient recovery by modifying physiologic and psychological responses to major surgery. The concept of multimodal perioperative care pathways were first pioneered by Henry Cayley in the late 1990s with the intent to improve overall outcome by improving various elements of the healthcare system. The individual elements that comprise these enhanced recovery pathways are built on evidence-based principles that decrease mortality and morbidity and facilitate early discharge. For elective colonic surgery, these protocols were first drafted by the ERAS group in 2005, updated in 2009 to include rectal surgery, and most recently updated in 2012. Individual elements of these ERAS protocols address a patient's entire journey from pre-op to post-op. Since its inception, evidence in favor of ERAS has been well demonstrated in several randomized controlled trials, systematic reviews, and meta-analysis. Positive clinical outcomes have included decreased length of stay, convalescence, post-op complications without any increase in readmission rates. Patient satisfaction rates have also increased, while overall net costs have decreased. Barriers to successful implementation of ERAS includes lack of resources, lack of buy-in from all stakeholders, and resistance to change. Furthermore, the maintenance and sustainability of ERAS requires ongoing re-education, audit, and feedback. Military medicine, as we know, faces a number of unique challenges, to include lack of continuity of care, institutional memory loss, as well as staff shortages due to rapid turnover from deployments, TDY, and PCS moves that are not encountered or not often encountered in civilian hospitals. Because there have been no previously published studies analyzing the outcomes at a military treatment facility after implementation of ERAS for elective colonic surgery, or its comparison with civilian hospitals, we set out to investigate whether we can implement it successfully at our military treatment facility and achieve comparable outcomes with our civilian counterparts. Evidence-based medicine is the current standard of care, and quality improvement programs have become the standard means of quantifying patient outcomes. National databases can offer critical information on the best practices to improve overall healthcare efficacy in the setting of limited and finite resources. The NISCOP database offers a retrospective review of all surgeries within the United States. Our hospital was one of the participants in the Enhanced Recovery NISQIP, or ARIN initiative, that commenced in 2014 to help hospitals successfully implement ERAS for elective colonic surgery and to develop a robust data collection infrastructure to chronicle outcomes before and after implementation. There were 17 hospital participants of varying sizes from all regions of the country. Our institution was the only DoD facility within this collaboration, which gave us the opportunity to directly compare our data with those of various civilian medical centers. There were 13 process variables used to track compliance and 4 primary outcome variables. We hypothesized that we would be successful in implementing ERAS for our patients and achieve comparable outcomes with our civilian counterparts. The standardized guidelines for ERAS for our institution were developed in collaboration with multiple departments. An order set was created. In addition, a checklist was included within our medical record to track compliance. And lastly, staff education was provided to those within our clinics, surgical admission center, operating room, post-anesthesia care unit, and the wards. These were our results after implementation. The mean length of stay dropped to 5.74 days during the study period. We next looked at the data from the ARIN initiative. There were 1,876 cases identified among all ARIN participants, 34 or 1.8% of which were from our institution. With the exception of race, the baseline patient characteristics did not differ significantly in terms of age, gender, BMI, and ASA class. While ARIN participants were more likely to be white or unknown, our patients were more likely to be white or Asian Pacific Islander due to our region. The four primary outcome variables used to evaluate performance were post-op length of stay, return of bowel function, diet tolerance, and pain control on oral meds. The numbers shown in this table are mean number of days with standard deviation. As shown here, the four primary outcome variables did not differ significantly between the two groups. ERAS requires multiple components and is not a straightforward process. All those involved in patient care are critical to its successful implementation and includes those within our clinics, our operating room, our surgical admission center, and the wards. Additionally, for those of us in DoD facilities, this also means a commitment from hospital command towards a unified goal. To combat the lack of continuity of care and institutional memory loss, we can designate champions to provide that stability, preferably one on the physician side and another on the nursing side, to coordinate and communicate closely with one another regarding staff changes. Lastly, ERAS requires active maintenance, with consistent feedback and evaluation of track data, constant communication between providers to identify any weaknesses within the program, and re-education for all staff at regular intervals. To conclude, although successful implementation of ERAS is naturally challenging with its requirements for coordination, communication, and collaboration between multiple disciplines, it can be achieved in DoD facilities like our institution, where providers face a number of challenges typical of military medicine. This demonstration of similar performance outcomes should encourage all DoD facilities to adopt evidence-based medicine as their standard of care practices earlier to best optimize patient outcome and resource utilization. Thank you for your time. I'm happy to take any questions.
So I have to applaud you guys for doing this because I sit on our ERAS committee at the hospital, SAMC, and we are actually rolling this out. We've been doing this for colon surgery for a while, but we're rolling this out across all specialties now. And it does take a whole village to move mountains at this facility, let me tell you. But let me go back to asking you, your data that you showed in terms of your improvements in length of stay, return of bowel function. I noticed that return of bowel function, diet, and et cetera were at 3 days, but your length of stay was still at 5. So what accounts for the 2 days that they stayed additionally?
It can be a number of reasons, but those were not tracked individually. I don't have that information, unfortunately.
Okay, and I also think that 5 days is still pretty lengthy. Are you guys using Enereg for your colon surgeries?
I'm sorry?
Enereg, Elmevapan?
No, that is not part of our ERAS during this study period.
Okay.
Did you guys look at, I know this wasn't your primary outcome, but did you guys look at anastomotic leak rate between the two groups?
We did, and our rate was approximately 2.9%. That was 1 out of 34 patients that had an anastomotic leak rate within the 30-day period, and the rate among the ARIN participants was 2%. But a limiting factor was the amount of missing data from the ARIN participants.
I do have a question about the mechanical bowel prep. So I guess for ARIS, for the 17 institutions, they developed their own ARIS protocol, correct?
Yes, that's correct.
And then what was your particular protocol in relation for mechanical bowel prep?
For mechanical bowel prep, we do mechanical bowel prep.
So I'm going to bring up some literature here about mechanical prep and realize I'm a pediatric surgeon, so we don't do bowel prep whatsoever. You know, there are some studies that look at that in relation to anastomotic leak, superficial wound infections, and so forth. How did you develop your mechanical bowel prep based upon the literature? Because there is some conflicting information about that. So.
There is conflicting information about the use of mechanical bowel prep for ERAS. The standardized guidelines for each institution is developed based on the home institution across multiple departments. So I was not part of that process, so I don't know the background of that.
Thank you very much.